I welcome all to tonight's webinar of the Cancer Cachexia Society. Great that you're all here. I'm the chair of tonight. I'm Anouk Hiens. I'm working as an epidemiologist and assistant professor at the University Medical Center Utrecht in the Netherlands. And my sidekick of tonight will be Ros Dolen. But before we, there he is. Before we dive into our topic, Cancer Cachexia in a year, I would like to give more details on the upcoming conference, which is in September in Turin. The deadline or the abstract submission will open on the 1st of February. So I'll stay tuned for that and think about research that you can submit to this interesting conference. And we hope to meet you there. Then, of course, we also have some upcoming seminars in January. One from Andrea Bonetto. He will talk about access drives cachexia in musculoskeletal deficits in colorectal cancer, which will be very interesting. And in February the 12th, we will have Dr. Tony Cole, who will tell us more about neuroendocrine mechanisms in cachexia. Well, today we invited Dr. Alessandro Laviano. He is an associate professor of internal medicine at the Department of Translational and Precision Medicine at Sapienza University in Rome, in Italy. And his main research interest is in the prevention and treatment of disease-associated malnutrition, and particularly cancer, anorexia, cachexia. And more recently, he has extended his area of research to include the impact of biological aging in the pathogenesis of sarcopenia and the development of nutritional strategies to reduce accelerated aging and also favor healthy aging. Well, during the last decade, he has served in different roles with the central committees of European Society for Clinical Nutrition and Metabolism. And today he will focus on the field of cancer cachexia and will address different clinical questions that arose from the clinical studies and also a literature review in the cancer cachexia field. So I would like to give the floor to Alessandro, and I'm really excited to hear more about your story. Thank you.
Thank you very much, Anouk. Thank you, Ros. By the way, Ros is the guy with the bear, not the young one in the previous. So let me first share my. I hope you can see it nicely. So the topic I will address is what happened in terms of new discoveries or maybe consolidation of already existing evidence on cancer cachexia. Of course, before starting, it is important for me to disclose my potential conflicts of interest, which I summarize in this slide. Now, as a clinician, of course, I have to tell you why cachexia is important, and particularly why now cachexia is important as a clinical challenge, but also as a biological challenge. You know better than me that over the last 50 years, and these are data coming from the US, there has been a dramatic reduction in the mortality of patients with cancer. As you can see here, it's approximately 27% reduction from 1971 to 2019. However, you would say, okay, this is because of an improvement, for example, in the treatment, in the drugs which we use. Forget it. This is not true. Actually, as you can see here in this very nice paper published in JAMA Oncology, the majority of death averted during the last 50 years is just because of prevention and screening. So we still have a lot to do to improve the treatment of patients with cancer. Not only that, cancer is becoming a chronic disease. This is a nice figure showing the so-called time to cure, which is a surrogate marker on how long does it take for a patient with cancer to reach the same life expectancy as the general population. So you see that for men is approximately, you need approximately more than 10 years in order to have approximately 30% of patients with cancer to reach the same life expectancy of the general population, which means that the treatment of patients with cancer is quite long. Not only that, another important evidence is this. In 1973, approximately 80% of patients were dying because of the tumor. But you see that in 2013, these incidents went down, which means that now the patients are not dying because of the cancer. They are dying because of something else. Could be, for example, frailty, sarcopenia, maybe cachexia, because we know that cancer treatment has a negative effect on the physical function. Data from JAMA Oncology, you see that patients with breast cancer, colorectal, endometrial, lung cancer, they have a major drop in physical function when they start the treatment and when they, of course, are diagnosed with cancer. And which is the consequence? The consequences here is in this slide, clearly showing that we had over the last 20 years a major increase in cancer survivors, but the majority of these cancer survivors, they survive with functional limitations. So I would say that it's very much true that we can improve the outcome of the patient, but we still have to improve the functional status of this patient, which of course brings into debate the issue of cachexia. Over the last 12 months, however, there has been some debate of what is cachexia, because we know that based on the 2011 definition in Lancet Oncology, cachexia is anything which happens and is related to muscle mass. So quantitative or qualitative changes in muscle mass, which of course makes sense. But on the other hand, we know that over the last 10, 15 years, a number of studies came out really profiling the changes in body compositions of these patients. And now we know, for example, that there are patients with cancer. This is a study published last year in Nature Medicine, clearly showing that there are patients who actually have a muscle loss, maybe muscle loss alone or with adipose tissue loss. But there are also patients you see here with a specific change in adipose tissue. And what happens is that their survival is absolutely the same, so reduced, as those who have just a change in muscle mass. However, since our definition of cachexia relates to muscle mass, we have clinically two populations having the same survival, but one can be defined cachectic because there is a change in muscle mass. The other having the same outcome, they cannot be defined as cachectic because they have no change in muscle mass. And this has been also shown in this much recent paper published this year. Again, looking at hundreds and hundreds of CT scan, these were looking at L2 rather than at the standard of L3. But again, you can see that changes in subcutaneous fat area, visceral fat density, the so-called muscle to fascia ratio, you see here that there is a significant impact on overall survival, independently of the changes in muscle mass, which means that maybe in the next future, the key opinion leaders, the experts in cancer cachexia should convene to try to adapt the definition, the 2011 definition of cancer cachexia, maybe to include also other changes in body composition. This year, other important evidence have been produced showing that sarcopenia and cachexia are reversible. We were always thinking that, unfortunately, when you have cachexia, it would be very, very complicated to improve again your muscle mass. But we have now good data published this year that you can significantly improve the outcome. Of course, this was a concept already put forward by Carla Prado some maybe 10 years ago with these interesting studies showing that even at 3 months before death, you still have a number of patients, 60% of patients having the ability to stabilize skeletal muscle, and then there is also some who can gain muscle mass. But based on this evidence, we have now more interesting data. These are not patients with cancer. These are just adults, actually older adults. But you see nicely here in this study that you can have, of course, you can have patients going from non-sarcopenia to possible sarcopenia to sarcopenia, but you also see that patients or individuals with sarcopenia can go back to non-sarcopenia. And basically, as you can see from the number here, in 1 year transition, it's much more likely that you go from sarcopenia to non-sarcopenia rather than from non-sarcopenia to sarcopenia. And the same concept applies if you look at 2 years, 3 year, or 5 year transition. But what about actually patients with cancer? This is a recent study, again, a large study from China, but showing, it is very interesting. I think it's very interesting because it is not looking at only one assessment of body composition at the start of the clinical journey of a patient with cancer, but they are doing repeated assessment of body composition because the patients were receiving after 3 months, 6 months, 9 months, 12 months CT scan. So you see, indeed, there are a number of patients who has a low muscle mass, but then probably they can improve. And you see here that there are changes in the quantity of muscle mass. And how these variability in the quantity of muscle mass relates to what for me is important, that is survival. It's written here. Of course, the best survival would be of the patient who would have high muscle mass before starting the clinical journey and high muscle mass post starting the clinical journey. But you see, for example, that those patients who starts with a low muscle mass, but during the clinical journey have an improvement in muscle mass, they have the same survival as the patients who started high and remain high with their muscle mass, which means that the studies clearly showing the negative impact of sarcopenia at the beginning of the clinical trial could be misleading, because you may think, oh, if my patient at the start of the clinical journey has already sarcopenia, those studies show that he or she will have a poor outcome. But this is not true because of these very interesting and recently published studies showing, again, that you can start with the low muscle mass, but if in some case you are able to improve your muscle mass, also your survival is improving. Now, why is this happening in some patients, and why in some patients muscle mass is low and remains low? We don't know yet, but we may have some ideas. Some ideas because, of course, there is an improvement in our understanding of the pathogenesis of cancer cachexia. I like very much this very recent review paper, which highlights that unfortunately, cancer, unfortunately, it's a biological event, so we cannot say unfortunate, but unfortunately from the treatment perspective, the cancer cachexia is a multi-layered disease, which means that you have different level of involvement of a mechanism, going from the tumor, the host responses, and the tissue crosstalk. So, for example, muscle wasting could be due to protein synthesis and or increased proteolysis and or increased atrophy genes. So you see here that every single patient with cancer could be extremely different from the other one, even if they have the same tumor. And that's why maybe this is the reason for clinicians to have some difficulty in preventing and treating cancer cachexia. Now, of course, we now know a lot of the mediators of cancer cachexia, which goes from the standard, the traditional pro-inflammatory cytokines, IL-6, TNF, myostatins, the new kid in the, well, the not very new, but still the new kid in the block, GDF15, and all of these, they have different effects, and therefore, in clinical practice, cancer cachexia is really completely different and from patient to patient, and this means that we have to really look in detail each single patient. Now, for example, it could be also that cytokines like IL-6 could not be actually indispensable for cachexia. And so this study published this year in the European Molecular Biology organization reports clearly show that in some, even if you have a high expression and release or circulating IL-6, this appears in this model not to have a major effect on the quantity of muscle mass. So you see that the pathogenesis is quite complex. Not only that, I like to mention this recent study because we are maybe overusing statistical analysis. If you have some experience in statistical analysis, I recommend to look at this paper because, I mean, for me, it is even complicated to understand the abstract of these. But basically, the concept is, particularly on epidemiological study, based on a database, depending on the type of a statistical analysis, you can tell two different things. Let's say that you want to look at the impact of red meat on mortality. Then, on the same database, using different statistical approach, you may say, okay, the data tell that red meat increases mortality, or maybe using the same data, you can say, oh, no, red meat actually extends survival. So we need really to use statistical analysis based on, I would say, biological plausibility and clinical experience. Now, I told you before that the new kid in the block, there is a lot of interest about the GDF15. And of course, this kind of molecule appears to be extremely related to the development of anorexia and, of course, weight loss in patients with cancer. And interestingly, it appears also to be related to the negative effects on the body composition of chemotherapy. And in this elegant study in Journal of Experimental Medicine, it has been shown that in patients with colon cancer or with breast cancer receiving chemotherapy, there was a significant increase in plasma GDF15 post-chemotherapy. And by blocking this molecule, which is actually a mediator located in the liver, you can have actually a negative, well, amelioration, significant amelioration of food intake and on body weight, which means that it is possible beyond blocking GDF15, as we will see in a moment, you can also block the mechanism, the molecular mechanism, which are involved in the synthesis and release of GDF15 to increase, to reduce the negative effects on body composition and on food intake. Now, as you know, I'm a clinician, so basically I'm very much interested in how translate these evidence, these laboratory evidence into treatment for human cancer cachexia. Do we had something interesting over the last 12 months? I think so. First of all, you know that there is a lot of debate about the use of omega-3 fatty acids. Are they effective in reducing inflammation and therefore improving the efficacy of anti-cancer treatment and therefore improving, for example, the outcome? This is a study published this year in Scientific Report showing that if you look at the plasma level of EPA and arachidonic acid, and particularly if this ratio is high, you can have indeed an improvement in overall survival in patients treated with immune therapy. So then we can speculate, why is this happening? Just because of reduction of inflammation, or just because reduction of inflammation improved, for example, body composition, and therefore the patients were able to complete the treatment? Unfortunately, we don't know, but it's very much evident here that if you have a high level of EPA in the blood, you have probably in the long-term survivor when treated with pembrolizumab. Now, look at the numbers, 12-8. So very interesting, but we cannot really build a recommendation grade A based on 20 patients. Another important aspect, another important drug. So we move from nutritional treatment to drugs. Of course, there is a lot of interest of anamorelin. Anamorelin is largely used in Japan, where it is approved. And you see that, of course, approximately I would say after 12 weeks, approximately 60% of patients with cancer have an improvement in appetite, and approximately 48% of these patients, they have an improvement also in body weight. And if they have an improvement in body weight, it seems that also you have an improvement, a significant improvement also in survival. However, if you look in more detail about this study, this data, you will see that not all patients with cancer will get benefit. In particularly, it's likely that your patient has a colorectal cancer rather than a gastric cancer. It's much better that the patient is not beyond the second line of treatment rather than the third or later line. So you see, we know that this drug could be effective, but probably not for all the patients. And that's why there is maybe some kind of hesitancy in using these drugs. Anyway, this is an interim analysis again of the use of anamoreline, and you see that in the overall population, and you see the number is more than 3,000, you see that there is a significant improvement, which is about 1.5 kilo in 1 year. And then, of course, as a clinician, I always think, but how much clinically relevant is 1.4 kilo over 1 year? Because no doubt that this could be statistically significant, but maybe it's not so important from the clinical point of view. And you see that, for example, some tumors like the colorectal cancer, you have this very nice increase. But in patients with lung cancer, you actually have an increase after 12 weeks, but then a progressive decline of body weight gain, which again highlights that in patients with cancer, there is such a variability of factors that not necessarily a drug can be effective in all of them. And one of the goal of the clinical trials is try to understand which is the patient who will benefit the most from this treatment. Now, there is also an interest in improving appetite. This year, at the beginning of 2024, this paper was published in JAMA Oncology highlighting the potential effect of mirtazapine as anti-appetite stimulant. I remember to myself that mirtazapine is a serotonergic antagonist. So you see that indeed you have in patients receiving mirtazapine a significant improvement in energy intake, mostly driven by an improvement in carbohydrates. But things changes after 8 weeks. You see that in these patients, there is again an increase in carbohydrates, but the same increase also is in the patients receiving placebo, which, in my opinion, highlights that particularly when you talk about energy intake, you have to consider the psychological effects. And therefore, I'm very happy about this significant improvement. But on the other hand, we always have to remember that these results have been obtained under the safe umbrella of a clinical trial and not necessarily can be replicated in the real life. And then, of course, we were talking about the new kid in the block, GDF15. Quite recently, this paper came out in New England Journal of Medicine, and they were testing whether ponsegromab, which is an antagonist of GDF15, could have any effects in patients. These are patients with lung cancer, with pancreatic cancer, quite a number of them. And they were given at different doses, like 100 milligram, 200 milligram, or 400 milligram once a week for 6 months. So you see here that actually these patients were quite sick because 46% of these patients will actually have an increase in weight loss greater than 10%. Nevertheless, there was a significant improvement, quite an amount of increase in body weight for these patients, approximately 2 kilos. And interestingly, there was in the patients who were receiving 400 milligram of ponsegromab, they had also an improvement in muscle mass. If you look at the study, at the trial, at the paper, you will see also that there has been some improvement also in functionality for these patients, but not when using different tools, screening tools to measure the functionality of these patients. So very good, but why is this happening? Are they eating more? There is less inflammation. Which is the mechanism? We don't know yet, and I'm pretty sure that in the next future we will have a secondary analysis of this study highlighting the mechanism by which these patients were increasing body weight, and in the 400 milligram dose, also the lumbar skeletal muscle index. Now, let's move to a really new. I'm very much interested in this topic which we are going to address, which is the so-called time toxicity. Well, time toxicity means that patients with advanced cancer have a lot of time spent in hospital. So it's called time toxicity. But I like the concept time toxicity in order to address the issue of the acceleration of biological age. Now, we know very well that cachexia has many potential pathogenic factors, but we still have to admit that the cachexia is an uncharted sea. What I would like to address is really the issue of not being older, but having a higher biological age. What do we know so far? Well, we know that as far as we age, in our body, there is an accumulation of the so-called senescent cells, or cells which are not dividing anymore. But unfortunately, they are not even dying because of apoptosis. They just release the so-called senescence-associated secretory phenotype. It's very interesting to see that treatment-related toxicity appears to be related to this increase of these senescent cells, which appears to also increase when you have a disease, when you have a cancer, for example, or maybe when you have a different disease. So in general, we also have to deal in patients with cancer with an increased number of senescent cells. Just to remember to you, when we asked how old are you, of course you have to say which age are you interested in, chronological or biological age, because chronological age is very simple. I mean, it's the same going from 18 to 19 years old as 85 going to 86. It doesn't change. It's not affected by anything. It's very much different regarding biological age. In biological age, we have period of stress in which we have an acceleration of age, and periods of maybe resilience in which we have a deceleration of biological age, and therefore we are younger than our ID states. Now, why is this important? Because let's imagine that at a certain point of lifespan, your patient has a catabolic stress. At that time, that would be his chronological age, but this would be his biological age. And this difference is called age acceleration. And there are now good evidence, clinical evidence, saying that age acceleration, particularly in the ICU, predicts much better the outcome of the patients. So, how this deals with the issue of cachexia and muscle mass? Well, a few years ago, David Glass, that we all know, published this commentary saying that if you have an injury, a muscle injury, and you have a number of senescent cells, so you are an older adult, so you have muscle injury, the presence of these senescent cells by releasing the secretory associated phenotype reduces the ability to repair the muscle injury. But if you use specific drugs, you can improve the repair, which means therefore that senescent cells may be also responsible for changes in muscle mass. Now, when we ask, okay, but what is the senescence-associated secretory phenotype? Well, it's much more than cytokines. It's a lot of different factors. These are just a few of them. You see cytokines, bioactive lipids, chemokines, a number of them. But if you want, this is a recent study published this year in Nature Medicine. These are ladies, older 80, with osteoporosis. And you see that the list of what is secreted by the senescent cells is quite high. But you see there is GDF15, there is IL-6, there is a number of different molecules in the blood which are related, of course, to the presence of these senescent cells. Now, what is extremely interesting is that biological age reacts to stress and is able to decelerate during recovery. And this has been demonstrated in many, many different clinical conditions. For example, the acceleration related to the life of the individuals. These are patients with COVID-19 in which the use of tocilizumab was able to reduce biological age, and these are the patients who are getting the most benefit from the drug, recovering from the drug. But there are a number of different, for example, you know, maybe better than me, that even pregnancy is associated with an acceleration of biological age, but there is a deceleration after delivery. Actually, the lady returns younger than when they started the pregnancy. So is it possible that we can address the aging, the biological age, the so-called senescence-associated secretory phenotype in order to improve cachexia? So quite recently, this paper came out, and the model was very easy. I have an animal, and then I induce cachexia by chemotherapy. And you see that indeed you had the vehicle, the FOLFIRI, and the FOLFIRI plus this new drug SR12343, and the results are quite interestingly. For example, you see that the use of this anti-aging drug SR12343 is associated with a significant improvement in the matrix of the muscle. Not only that, you can also have a significant reduction in markers of aging. So in a few words, the animals appears to rejuvenate, I would say. And as you can see here, indeed, there is an improvement in body weight. There is an improvement which is significant of approximately 7 weeks of treatment in lean mass, no major change in fat mass, not very much improvement in treadmill, but significant improvement in the grip strength. Again, this is animal model. It's very preliminary data, but it seems that, at least in part, aging, biological age, is involved in the pathogenesis of cancer cachexia. And in the end, of course, just the graphical abstract shows that chemotherapy gives clinical signs of cachexia, while the use of xenomorphic drugs is associated with a significant reduction in these signs of cachexia. Now, it's very much interesting, this issue, because even the anti-cancer drug, so the PD-L1 drugs, the immune checkpoint inhibitors, they have a negative effect on aging. So in a few words, if you want to rejuvenate, at least from your biological age, you can have a shot of immune check inhibitors, even if you don't have a tumor, because they have a significant impact, an anti-aging impact beyond, of course, the effects on tumor growth. And then, if this is true, so what if biological age acceleration has a role in cancer cachexia? How can we use this information in clinical practice? Well, there are different strategies in order to reduce biological age. Of course, you can use a drug. We will see there are many drugs which can have these anti-aging effects. So you can use drugs, or you can use exercise, or you can use nutrition, and particularly the so-called long-term fasting. And this is the fasting mimicking diet. These are, I would say, healthy young person, in which the use of cycles of fasting mimicking diet is associated with a significant reduction in biological age. In some way, they rejuvenate of approximately a couple of years, something like that. But interestingly enough, when you apply fasting mimicking diet also in patients with the triple negative breast cancer patients, then you have a significant improvement for what is called overall survival. Again, look at the numbers here. Unfortunately, they are very, very low. But anyway, it's suggesting that in case the patients do not have any risk of malnutrition, and that's why breast cancer patients are always used, you may consider that modulating the quantity of the calories and the proteins, you can improve the efficacy of anti-cancer treatment. And what about other nutrients? For example, like omega-3 fatty acid. I showed you before that there are some suggestions that they can have a positive effect on the outcome of patients with cancer. But are they also in some way anti-aging? Again, another recent study showing that indeed, based on the daily dose of omega-3 fatty acid, you have a reduction in the, I would say, age acceleration, with the best effect approximately at 2-3 grams a day, which, by the way, it's what we always say for patients with cancer. And indeed, this is a nice study, a dose response meta-analysis, showing that probably the best, I would say, the best dose of omega-3 fatty acids in patients with cancer cachexia is a little more than 2 grams a day, which again is similar to the dose you need to reduce biological age in healthy individuals. Now, what else we can do? Well, for example, we can in some way coordinate our patients to the so-called rhythms, the circadian rhythms. So as an example, increasing the overnight fasting. In this case, you don't really have to reduce the quantity of calories and proteins, but actually you have only to, I would say, reduce the time in which you actually the patients receive their food, and extend the fasting period. So not really reducing the quantity, but actually just reducing the time during which the patients are eating. And this is a very interesting study recently published, showing that maybe there are a number of drugs which may have these anti-aging effects. This is a very interesting study. It is based on a large database, a US database. So these are patients with heart failure treated with these drugs, which are these SGLT2 inhibitors, which is a sodium glucose transporter, which are frequently used in patients with heart failure, with diabetes. And the author was saying, what happens if one of these patients receiving this drug develop cancer, is treated with anthracyclines? So what happens in terms of the ratio of developing cachexia or malnutrition? And interestingly, it seems that if the patients are on this type of treatment, they have a significant reduction in the risk of developing cachexia and malnutrition. Like these drugs could be could have a protective effect. And by the way, there is a recent paper, which I did not put here in this presentation, showing that SGLT2, beyond their known effect on glucose homeostasis, they have an anti-aging effect. So right now we are looking at the same database, trying to see whether other drugs which are used for a different clinical purpose may have a similar effects. Now, we are also thinking, we are really very much interested in these biological age. Of course, we did this study together with Professor Hanping Shi from Beijing. The paper is under review, but if you're interested to see, you can go in the preprint and look at our paper showing that either in healthy person and in cancer patients, the biological age is really highlighting the possibility of identifying the patients at a higher risk. Now, to conclude, believers versus non-believers, because I am a clinician, and I'm pretty sure there are many PhD or biologists who are watching this, well, at least I hope. And we may have a different approach. So why believers versus non-believer? Because we had recently at a conference a large debate regarding the so-called a miraculous paper. A few years ago, this paper came out in Clinical Nutrition showing that if you have a patient with gastric cancer undergoing surgery and they receive after surgery for 3 months an oral nutritional supplements, there is a significant reduction in the prevalence of sarcopenia, but also significantly less chemotherapy modifications, including delay, dose reduction, termination. Now, everyone in 2021 will say, oh, that would be interesting to see whether those who had significantly less chemotherapy modifications also had a better outcome. And indeed, a few days ago, the paper came out, the secondary analysis of that prospective randomized trial, showing that indeed you have a significant reduction in survival after 6 years. Now, of course, look at the number here of the patients, but the big debate was, but how is it possible to buy the concept that 3 months of standard oral nutritional supplementation can have an effect after 5 years? From the biological point of view, it's really complicated. So we had this major discussion. But basically, as a clinician, we may be more believers than non-believers. And I'll tell you why. Let's say that you have a patient with cancer, and he has to start a journey, and the journey is like a railway. Let's say that after 5 years, you can go to Milan, so the north of Italy, or maybe to Naples in the south of Italy, which could be, you decide where, a good prognosis, a bad prognosis. But let's say that during the first kilometer of your journey, you have a key railway exchange. So what happens if what you give for really limited time, but in a key period of his long journey, helps the patient to take the right railway? So I know it's more philosophical than biological, but think about it, because if it is true, well, we already know now which should be the outcome measure of all studies testing, for example, drugs or nutritional supplementation on cancer cachexia. So in conclusions, I think that the traditional model of muscle-centric cancer cachexia is being challenged. And maybe this debate is influencing the development of reliable screening and diagnostic tools. There is also robust evidence showing that sarcopenia and cachexia are reversible. This is a very, very good news, although the mechanisms are still unknown. And the increasingly appreciated multi-layer pathogenesis of cachexia may explain the limited efficacy, the limited clinical efficacy and effectiveness of currently developed treatments. So I'm not saying that we have to develop a personalized, individualized treatment of cachexia, but we have to take into consideration many different aspects. And maybe also the modulation of biological age in patients with cancer could be an emerging and promising area of investigation. So thank you very much for your attention, and I'm ready to answer your question.
Well, thank you very much, Alessandro. It was very nice to hear all the literature, all the recent literature on this topic. And for me, it was really refreshing. So thanks for that. I would like to invite everyone to ask their questions in the chat, and we would like to address them now. Well, first, I also had a question. In the meanwhile, people can start
Yeah.
getting their questions into the chat. But I was wondering because the most studies were focusing on treatments, so medical treatments. But I was wondering, and you also said like there are limited effects of these treatments. So I was wondering, how do you think about, or have you read about it in the literature about a combined treatment? So it's medical treatment combined with nutrition and also exercise, because I think also exercise is really important
Yeah.
in this case. How do you?
Absolutely, yes. Absolutely, yes. There are, I believe that, for example, there is this emerging field of prehabilitation, which has been used many times or more frequently in surgical cancer patients. But I can tell you that there are studies going on, for example, Gustave Roussy Cancer Center, about prehabilitations, including, of course, physical activity and exercise in medical patient with cancer in order to better prepare the patients in order to, I would say, have the less modification of the chemotherapy and so on. So definitely the combination of these is probably at this time when we don't know in any specific patient which is the factor best explaining cachexia. Well, at that time you have to use basically everything you have in order to improve the outcome.
Yes, yeah, thanks. I think they can indeed work synergistically. That would be great. We have a question from Katja
Yeah.
Stein, and she is asking whether there are any studies on the diagnosis and treatment of cachexia in the pediatric cancer patients.
Oh, yes, yes, of course. It is also cachexia is also challenged with the in patient with pediatric cancer. Now, one of the major challenges in the next future will be the so-called AYA, adult and young adults, which basically are the patients who survived a childhood cancer. Now, it appears that these patients are at a higher risk to develop secondary cancers or even diabetes, hypertension. So something happens during the treatment or during the growth of the tumor, or maybe during the treatment, which has a negative effect on these patients. So considering that we will have more and more cancer survivors, I think we have to consider the fact that our interest should focus not only on patients at the diagnosis, but also patients who has already maybe survived the cancer, because even if there is no more cancer, for sure they are at a higher risk of developing chronic diseases.
Yes, thank you. Then we also have a question from Julio Sylvester. Thank you for the fascinating talk.
Thank you.
I've been following the topic for a good while. My question, a little bit off topic. In the wake of the discovery of that GLP-1 agonist might reduce cancer risk for obesity-associated cancers, would there be any chance that GDF15 inhibitors might actually increase cancer risk and or blunt systemic treatment effects? I know that they have widely different mechanisms of action, but I wonder if you have any thoughts on this topic.
We don't know. We know that it appears that this class of drugs work for everything. You want to have blue eyes, take the GLP-1 receptor. You want to be 10 centimeters tall, take GLP. It works for everything, including alcohol abuse. So for sure, we know that they may increase the risk of sarcopenic obesity, particularly because quite a proportion of weight loss is because of a loss of muscle mass. So this is a significant problem. There are a number of networks working about these negative effects. For example, probably you know that many years ago there was this anti-myostatin drugs, which is now repurposed to prevent sarcopenia in patients with GLP-1 receptor agonists. In the next year Congress of the American Society of Endocrinology, they will present the data of the Believe study, in which the GLP-1 receptor antagonist and the anti-myostatin will be given together to see what happens in terms of loss of muscle mass. So let's wait for the meeting next year.
Yes, interesting. Then a question from Klaske. Dear Alessandro, thank you for your nice talk.
Thank
I
you,
like
class. Lauren.
he likes particularly your summary on senescence and on the circadian rhythm. Have you any idea how they influence these mechanisms, or
Oh,
how to influence these mechanisms?
we don't know. We know for sure that patients with having a shift work, they have a higher risk of developing, for example, diabetes, hypertension, obesity. So definitely something that is there. Why is this happening? We don't know yet.
So more research needs to be done here.
Yeah,
Yeah.
absolutely.
Another question from Fabio. Also, thanks again, Alessandro, for the nice journey.
Thank you, Fabio.
About the trajectory modification, we definitely need to demonstrate that anti-cachexia intervention modify the cancer trajectory. Do you agree?
Definitely, yes. You know, there is this big debate because sometimes um, you have, for example, as a reviewer, look at the results of a trial in which they show that you have an improvement in body weight, but from the clinical point of view, this is not really what we are looking. We want to see whether the patients in some way goes better in terms of quality of life, in terms of better tolerance to the treatment, and definitely the challenge is, of course, trying to see whether you can revert. And it would be nice to see that at least part of these improvement of muscle mass is because of our treatment. Could be exercise, could be omega-3 fatty acid, more proteins, whatever.
Thank you. There are still more questions coming in. One from Adam, Falvi. Also, thanks again for the great presentation. And do you observe any effects of the microbiome and the microbial metabolites on cancer cachexia, or does cachexia influence the microbiome?
For sure, there is an association between the so-called dysbiosis, whatever dysbiosis mean, and the presence of cachexia. It's difficult to say whether it is cachexia inducing dysbiosis or dysbiosis inducing cachexia, but for sure, there is definitely an association between them. There have been in the past some trials of fecal transplantation to see whether these would be improve the outcome. This was mostly done in the patient in the I would say pediatric patients from the developing world, in which there was a lot of course, these infections in the gut, and fecal transplantation was associated with a better outcome in terms also of muscle mass for these pediatric patients.
Okay. Also an interesting question about the SGLT2 inhibitors. The thing is that those inhibitors also increase basal metabolic rate as it secretes out this glucose. And how much of this protective effect do you think it's reduced by this effect? And also GLP-1 agonists decrease the muscle mass. And how do you think this will impact cancer cachexia?
Absolutely. I fully agree. Again, for the GLT2 inhibitors, we don't know why it seems to protect so nicely from cancer cachexia. Could be anything. Regarding, of course, GLP-1 in a patient with cancer, of course, I would not recommend any patients with obesity and with cancer to start any kind of GLP-1 treatment, because of the higher risk, as it has mentioned in the question, the higher risk that you worsen the muscle loss of these patients.
Okay. Thank you. Then I also have one more question. You were
Yes.
also looking into you showed the results of the fasting mimicking diet, and
Yes.
those were impressive results, I think, although the small sample size. Do you know what the adherence was to the fasting mimicking diet? Because I can imagine that in cancer patients, this would be really difficult to adhere to.
Oh, Absolutely. But if you look at the literature, 99% of the trials, the pilot trials, the preliminary studies are done in breast cancer, in which the issue of severe malnutrition is very limited. So I agree with you that in case anyone would like to test these in pancreatic cancer, in lung cancer, well, you have to be a little more cautious. I'm not saying it will not be ethical, but you have to be really strict in the follow-up of these patients because the risk of worsening. I mean, ideally, you should not worsen cachexia, but the risk is there. So you have to be very cautious. I'm pretty sure that there could be positive effects, but the trial should be really well designed.
Yeah, totally agree. Thank you. It's almost 7 o'clock, at least in the place where I live. But we have one final question from
Yes.
Paola, if that's okay. Again, thank you for your wonderful review of the literature. Also taking into account the last study you mentioned, how would you assess the right moment in which adequate nutritional support and/or exercise should be applied to match the anabolic window in cancer patients?
Thank you, Paula. Thank you for the key question. I believe that the window of opportunity is really when the patient is about to undergo a major and significant treatment. I mean, the perioperative period, or rather when the patient is receiving chemotherapy, systemic chemotherapy. So I think that is the point at which probably the use of combined nutritional support, meaning calories, proteins, and then we may discuss ages, how many calories, how many proteins. But anyway, specific nutrients can be, of course, in some way helping the patient to take the right railway exchange and go to Rome, where all the road bring to Rome.
Great. Thanks. Thanks for answering all these interesting questions. Thanks for your great talk. Then I would like to wrap up this interesting webinar. And I would like to end it with some slides very shortly. Because we have, like I already said, upcoming webinars in the new year, but we also have training talks coming up in April 2025. And we will distribute more information early next year, but you can sign up from January onwards. So keep an eye out on our website and we will share more details about it soon. So then I wish you a great night and also, of course, happy holidays for the upcoming weeks. Enjoy and see you next time. Thanks a lot.
Happy holidays to everyone. Thank you so much.
Thank you. Bye-bye.
Bye-bye.